Hey everyone, it's Casey. I'm the current president for MACVPR, and glad you all could hop on today. Uh, this is going to be the first webinar for our year. Again, we're unable to meet in person, but we're hoping that's right around the corner where we can have a conference together again. But for now, this is the way to continue with education for everybody. And just a reminder with these webinars that we're doing, please enter your questions in the Q&A box so we can wrap back around at the end here to get those addressed by Reed today. You can use the chat feature if you'd like, but please put all your questions in the Q&A field. And just to let everybody know, this is being recorded, so you'll be able to come back to this presentation if need be. We'll post this on our MACVPR website at the end of this, so you guys can have this for other needs coming back to it. With that said, I'm going to turn it over to Mike to get us going here.
All right, thanks a lot, Casey. It's my pleasure to introduce today's speaker, Dr. Reed Humphrey. Dr. Humphrey is past president of AACVPR, the Virginia AACVPR affiliate, and the World Council of Cardiac and Pulmonary Rehabilitation. He has over 100 publications in exercise and chronic disease, including co-editor of 2 ACSM texts on exercise testing and prescription. He was elected as Master Fellow by AACVPR in 2012 and received AACVPR's Award of Excellence in 2007. He's the acting provost and vice president of academic affairs at the University of Montana. So Dr. Humphrey, go ahead and take it away.
Mike McNamara, thank you.
Reed, we lost your audio or your video, excuse me. Reed, we lost you. You may need to come back in again. Yeah, I think so.
Looks good.
So. Okay, so let's, this might be a really helpful slide, actually. Mike, you could just go through that whole introduction again, and by then it'll be 1 o'clock. But again, thanks folks for hanging in and appreciating that the internet gods may or may not be playing nice with us today. This might be maybe a super appropriate slide. For those of you who would recognize the Back to the Future rig and the need for a flux capacitor to just get back to some earlier point in time when we were all able to meet 3D instead of continuous 2D meetings that I'm sure that you endure probably not nearly as much as I do as an academic administrator now, but how much I miss patient care. I think where I was in mid-stride when we lost the internet was with the observation that that was like, oh my God, I have so much on my plate. Like, how do I pull this together? But then, actually, the opportunity to talk to my colleagues in cardiac and pulmonary rehabilitation really provides a break from the sort of like the craziness of trying to run an academic institution, which is and it's in my wheelhouse, but how much I miss cardiac and pulmonary rehabilitation, the opportunity to interact with my colleagues, and then just coincidentally, John Myers from Stanford and Joe Niebuhr from Austria, and I just finished getting a paper into Journal of Cardiac and Pulmonary Rehabilitation on prehabilitation. So you should see that soon, and that was a part of a presentation we did at AACVPR, I think just a year ago, but I'm kind of losing track of time. In any event, so I don't want to overwhelm this group with slides, so I wanted to stick to things that I think are really important. You all have guidelines on your shelves from AACVPR or ACSM that talk about the contraindications and indications and monitoring patients during exercise, and to some respect, and certainly on how to manage patients with chronic heart failure in exercise training. So, but one of the things that I learned, and that's part of the reason I have this particular slide up, is that I've often said I'll probably end my career the same way I started it, and that is providing continuing education to physicians and other caregivers and people who are gatekeepers for cardiac rehabilitation programs. And that's so important, I think, because we've known since the mid 90s that exercise training for patients with chronic heart failure was appropriate. The interval between 1995 and today has shown that, like, just as we demonstrated before 1995, the extraordinary benefits that exercise training and risk factor reduction has on patients with who are post myocardial infarction or with diagnosed coronary artery disease. But as if you went all the way back to the ACSM guidelines of 1975, in the absolute contraindications, that was the first, by the way, that was the first set of ACSM guidelines that were published. There was and actually when I got started in cardiac rehabilitation, it was the same year, 1974, 1975, in North Carolina. So when we began to look at the admittance of patients to exercise training programs, an absolute contraindication was congestive heart failure, of course, acute myocardial infarction, and some other contraindications as well. But patients with heart failure were considered were contraindicated for exercise training at the time, and just as their predecessor patients with MI or angina were advised for bed rest and modest home walking, but not admitted to cardiac rehabilitation programs, and not reimbursed for exercise training either, which was, of course, a bit of a deal breaker. So there was a time when, in fact, we simply wouldn't admit those patients. But so we're going to I want to take you through a little bit of a time sequence here. And for those of you who know this literature, just sit back and relax or multitask. But it's what I've found really interesting over the years has been the unique ability of individuals to forget what the literature looks like, or to be trained by clinicians who are hanging on to kind of dated literature. But really, you can go back as far as 1993. This was sort of a seminal paper. It was in Circulation, and what this paper was demonstrating was that left ventricular ejection fraction, which you can see on the left in the slide, when you correlated that to measures of peak oxygen uptake, and which, of course, our best measure of fitness, that there was an extraordinarily poor correlation between those two factors. So the primary fear for patients with chronic heart failure was that their ejection fraction wouldn't be able to sustain a program of physical activity, and in fact might be worsened by increased stress on the heart, right? So if you look at the slide and you look in that lower left-hand quadrant, those are your patients who were at that time and even forward considered to be prime candidates for transplantation. You can see a peak VO2 of 13.5 to 14 ml per kilogram per minute, or just like 3 or 4 METs at peak, and then likewise combined with low ejection fractions below 30%. And those were the high-risk patients that were considered candidates for cardiac transplantation at that time. But then, if you take a step back and you look at the scatter plot, what you'll see, of course, is patients with really depressed left ventricular ejection fraction. Actually, a significant number of them have relatively high VO2s. 20 to 25 ml per kilogram per minute, on the order of 7 METs or so. And then likewise, as ejection fraction increase, you could actually have patients with relatively high ejection fractions and, of course, really low VO2s, right? So, and if we repeated that study today, with a similar number of patients with the similar ejection fractions, we'd see the same scatter plot, really. So, but it was a consideration relative to candidacy for exercise training. Now, I want to talk just for a moment, if you would, if you'll indulge me, about the issue of exercise training and worsening cardiac function. And this is why I think it's important to take some time to talk about the history of the research and assumptions that have hung around a really long time. In fact, you might have personally experienced interfacing with a gatekeeper for a primary care physician or cardiologist or other gatekeeper for cardiac rehabilitation who still believe that exercise training can worsen cardiac function. And it finds its roots, and I just put up these 3 papers because that's about all there was. We had 2 rat studies done in the 90s, but the paper that really hung around kind of like a bad hangover was the paper by Judgett and his colleagues, American Journal of Cardiology back in 1988. And it was a small number of patients, but it did show that there was a 13% decline in ejection fraction, volume expansion, wall thinning asynergy in patients with heart failure as a result, in association with exercise training. I like to pick on the Judgett paper a little bit, partly because this was a paper that came out of Duke, and as Mike McNamara knows, I'm a Wake Forest graduate, and so anytime we can take a shot at Duke, we will. But here's the counter, right? And this only goes up through 2006. There have been subsequent papers as well. There are papers even prior to the Judgett paper, and certainly forward, that showed that exercise training does not worsen the ventricular remodeling process. In fact, there have been papers that have demonstrated that left ventricular function actually can improve. But I don't think that's where we would want to hang our hats as cardiac rehabilitation professionals. I think the maintenance of cardiac function, the improvement in I think in left ventricular dynamics and cardiac function, probably is partly a function of just the overall improved physiological profile of patients, as opposed to like hanging our hat on the prospect that exercise training was really remarkably changing left ventricular function. But importantly, it does not reduce left ventricular function. And mea culpa for Judgett and his colleagues at Duke, but the 3rd paper on that list is by Marty Sullivan, who is actually out of Duke as well. So, and right around the same time. So but what's been interesting is in all of these years forward, the importance of being able to cite the literature to convince caregivers that patients with chronic heart failure, when appropriately admitted to a cardiac rehabilitation program that includes exercise training, is appropriate. It is not harmful based on any of the literature. So the key point: exercise training does not worsen ventricular function in patients with heart failure. And there have been papers, again, as I mentioned, it has shown some measures of improvement, but I think that as cardiac rehabilitation professionals, our best bet is to encourage caregivers to appreciate that there's no worsening of ventricular function. So how do so when you think about that, how does that explain the poor correlation? And so for those of you who've languished through your exercise physiology or clinical exercise physiology training, and you're going to look at this slide and say, yeah, I know that, of course, but it's not clear. It's not clear to patients, not clear to caregivers, not clear to others that improved fitness, which is, of course, is directly associated with reduction in mortality and morbidity after exercise training. It's the most powerful predictor, really, of reduced morbidity and mortality. particularly when you combine it with an intensive risk factor reduction program. But oxygen consumption, VO2, is like the singularly most important variable when looking at improvements in morbidity, mortality, quality of life, and so forth. But VO2, as you know, is a function of both a central component, heart rate multiplied by stroke volume to equal cardiac output, times the VO2 difference. In other words, what happens at the level of skeletal muscle. And that it's this equation
Looks like Reed is frozen. So just bear with us here.
Hi, folks. Yeah, I'm back. Let me get back to where I was. Okay, so let's all keep our fingers crossed that the internet stays with us. If not, I can come back another time as well, or we can do it however you want to, Mike. So this is the important consideration, right? Is like depressed left ventricular ejection fraction is not a contraindication exercise. Left ventricular function is not worsened by exercise. And the real payoff for patients, of course, is the improvement at the level of skeletal muscle, right? So that's critically, that's critically important, right? So knowing that, and knowing that of course, there are contraindications to admittance to cardiac rehabilitation programs for patients with chronic heart failure, but they're really no different than the contraindications that you would expect to see in any patient with diagnosed coronary disease. So certainly you look for contraindications that might be exacerbated by low heart failure, by chronic heart failure, such as symptomatic aortic stenosis or the like. But those would be contraindications that you would consider anyway. So let's get past the admittance to a cardiac rehabilitation program. And what I thought would be a useful contrast in time we have, appreciating that I wasn't counting on being bumped from the internet from time to time, was to sort of summarize what we know about cardiorespiratory endurance and resistance training, which is also important with patients with chronic heart failure, but also to contrast that with other strategies such as high intensity training that have been attempted with patients with chronic heart failure over the years, really over the decades, right? So the guidelines for cardiorespiratory endurance, not surprisingly, not a lot different than those with coronary artery disease. Intensity somewhere above the ventilatory threshold, which would be somewhere between 40 and 80% of heart rate reserve, or, and this is really important, as you probably all know, using a perceived exertion, and this is using the 6 to 20 grade scale, okay, of 11 to 14, which is fairly light to just over somewhat hard, okay? It's not quite hard, which is a rating of 15. But for patients on cardiodynamic medications, of course, and when they get changed, it's really difficult to prescribe just by heart rate. I have found over the decades, really, that RPE is a very, very powerful indicator, especially when patients are read the instructions properly and can reliably use an RPE scale. It's extraordinarily valuable, particularly with respect to situations, and some of you may be in those situations where an entry-level cardiorespiratory exercise test in a timely fashion isn't possible, but the patient is still cleared for cardiac rehabilitation programming. There is sometimes that's a sticking point for programs and facilities that I got to wait for either a full-on exercise study to be done, or I want a cardiopulmonary exercise study to be done. let not the perfect or good be or the best be the enemy of the good. I have had a great deal of success with simply putting patients who don't have contraindications, who are been referred for rehabilitation, but sans an exercise, a recent exercise study. I've had great success walking those patients through a submaximal exercise protocol. And I walk them through a protocol that just takes their RP up to 12 or 13. And then I call it good because I've got the information I need. I have heart rate data. I've got RPE data. I've got symptomatic data. And hopefully I've got electrocardiographic evidence that they're not ischemic. And I may have been able to use that really quite reliably in guiding the exercise intensity for those patients. Because as we know, that ventilatory threshold, that is the point at which patients become more breathless with exercise, but that's always the sweet spot because that's where the peripheral muscle adaptation is really taking place and optimized. That's going to vary. That can vary quite a bit between individuals. So the less fit individuals will have lower thresholds. More highly fit individuals have higher thresholds. And then it's everything in between. And it will change over time, of course, as an individual improves their cardiorespiratory fitness. So setting that intensity around an RPE, extremely helpful. If you have an exercise study and you can look at heart rate data, that's helpful too. But I think that the subjective response of patients are so important. And of course, the minimum frequency is 3 days a week, preferably most days of the week. And to optimize body mass and likewise get an improvement in fitness. Of course, it's not linear. 6 days a week doesn't result in twice the fitness as 3 days a week, but it can be important, right? And then the duration can range anywhere from a minimum of 20 consecutive minutes up to 60 minutes in a session. So, and those are sort of like the broad cardiorespiratory endurance guidelines. Now, the monitoring of patients with chronic heart failure during exercise, not a lot different than monitoring patients without chronic heart failure. Of course, we pay more attention to blood pressure, but again, the guidelines have changed over the years, and the important take home relative to blood pressure changes is that the decreases in systolic blood pressure during exercise really should be associated with signs and symptoms of pump dysfunction, dizziness, and the like. So always monitor not just blood pressure, but also the symptomatic response. When we first started doing telemetry monitor programs in the 70s, where again the guideline for terminating exercise was a drop of 10 to 15 millimeters of systolic blood pressure, irrespective of symptoms. And then we discovered, of course, when we put patients in monitor programs, that in fact it was not unusual at all for their blood pressure to drop 10 or 15 millimeters of mercury with the onset of exercise, primarily because it was just sort of a cardiovascular adaptation, and they tended to be sort of revved up with a baseline blood pressure. But once they began to exercise, there actually was a drop in blood pressure, but it was a moderated blood pressure that was relative to the vasodilatation that happens with exercise. So symptomatic decreases in blood pressure, of course, critically important. And so those of us who are writing exercise programs for patients with chronic heart failure have a pretty big range: 20 minutes, relatively low intensity, that can be guided by RPE. I want to contrast that in a moment with what we know about high intensity endurance training, but I don't want to go there without emphasizing the importance of incorporating resistance training in patients with chronic heart failure. All patients with diagnosed cardiovascular disease as well. Again, there was a time when it was all cardiorespiratory exercise and almost zero resistance training, because there was this fear that resistance training would inappropriately increase intrathoracic pressure and could be harmful to a healing myocardium after myocardial infarction, or it might worsen patients with chronic heart failure. Again, we have not seen that in the literature. And what we do know is that resistance training on some level is important for all patients. And so that the guidelines that you will find are the classic 8 to 10 muscle specific exercises that begin with resistive bands, moving to weight machines, handheld weights, or combination. And the important take-home message here, is you probably would remember from your clinical exercise physiology days, is one set is fine. The classic 2 to 3 sets is that one hears for optimized weight training is in contrast to what we know about sets and reps. And 10 to 15 reps, one set, will result in a demonstrable, statistically significant improvement in muscular fitness. If patients are driven to 2 sets, that's all well and good, but they should appreciate that the outcomes that we desire relative to resistance training can be achieved through one set. Again, there's different approaches, as you know, to prescribing intensity for resistance training. I'm not a fan of 1RM testing in any case. I think that clients or patients that can do 10 to 15 repetitions before becoming fatigued, and they can use good form, is plenty. And then they can progress by way of weights associated with maintaining that repetition range, if you will. So one set, 2 to 3 days a week. Typical duration would be 20 to 30 minutes a session, although that's not really dependent. The key variables for resistance training is the one set, 10 to 15 reps, or sometimes additional reps, depending on what the patient likes, quite frankly. And 2 days a week should work just fine. So the balance of cardiorespiratory endurance training with resistance training optimizes the outcomes for patients, whether it's chronic heart failure or diagnosed cardiovascular disease, or they're just carbon-based life forms. Okay, so but I did want to spend a few moments with you talking about high intensity training. That's and for those of you who've been around the block a few times, that's not new. That's not new, right? We've looked at high intensity training or HIIT training in some form or another for the better part of 20-25 years. It's been interesting to follow this in the heart failure literature because the earliest work done around high intensity training in patients with chronic heart failure was out of Europe, Katrina Meyer and some of her colleagues as well. And the rationale behind high intensity training in the early 90s, quite frankly, was this hypothesis that if you did very high intensity training, and by that I mean upwards of 100 to 120% of VO2 max. In other words, what Meyer did was she did a steep ramp exercise protocol with her patients on a cycle ergometer, because that's what they use in Europe. And they would do a steep ramp exercise test to volitional fatigue or some other typical endpoint, but then would actually prescribe the exercise as 10 to 15 or 20 seconds at 120% of that workload, because you could tolerate that, right? Because in an incremental steep ramp or incremental exercise study, it's a real test of aerobic capacity. But there is, of course, the ability to exercise at higher levels using anaerobic pathways, but they only last for 10 to 15 seconds, right? So what Meyer was trying, but the rationale behind this was that Meyer was concerned about catecholamine production response in sustained exercise programs, and felt like that if you could do a high intensity, short duration program, there wasn't enough time for catecholamine production to really kick in. and it would decrease the risk of arrhythmias and the like. And what she was interested in finding out, and her colleagues, was, did you get the same sort of outcomes in terms of change in fitness with high intensity training? And that was sort of the genesis of high intensity exercise training in patients with chronic heart failure. I think what's been interesting over the years has been the use of high intensity versus moderate intensity versus low intensity, and what that actually means, because there are not really good operational definitions around that. So so if you think about the sort of time course relationship between the start of exercise training with patients with chronic heart failure and where we are today, the operational definitions of high intensity are quite different. If you went back to the early 90s, mid 90s, it was this short intervals, 10 seconds, upwards to a minute, but usually 10 to 30 seconds with a burst of activity followed by a rest, a rest period followed by another. And sometimes that would be like 4x4 or 6x6 bouts, if you would. And I have your variable work to rest ratios. Has always depended on the length of the exercise bout. We think about, a lot of us think about prescribing 2-to-1 work to rest ratios. So on for a minute, off for 30 seconds. But that sort of breaks down a bit when you extend the length of rest between bouts, or the length of the bout of exercise. So I pulled this paper because I think it sort of summarizes, I think, where a lot of HIIT training sort of falls now. I think that it was interesting to talk about high intensity training in the context of what we learned, like in the European studies. But then there was the obvious issue of like, well, that's all well and good, perhaps in Heidelberg, but I don't know that I'm going to be able to sell that in Billings or in Missoula or in Bozeman to my cardiology colleagues or my internal medicine colleagues that thanks for the opportunity to bring your patient into our cardiac rehabilitation program, and we're going to do a super high intensity program, because I still think that there are probably plenty of individuals who would think that's kind of crazy, right? Like, and in fact, when you look at the literature between moderate intensity programs to quote unquote high intensity programs, there's not a significant, HIIT training does not provide like a significant difference. In fact, no difference at all, really, in outcome measures like VO2, right? And in fact, one would probably argue, and I did early on in my career, that while HIIT training was an interesting way to approach exercise training for patients with heart failure or other patients, they didn't necessarily get at the caloric volume that we would hope to get to help manage other comorbidities, diabetes or obesity, and or even moderations in blood pressure. So, and there's not a lot of data. In fact, I'm not sure that I have my hands on any data that looks at HIIT training and reductions in morbidity and mortality. But you can hypothesize that if HIIT training results in an improvement in fitness, then, and we know that fitness does result in a reduction in morbidity and mortality, that you could make I think a pretty empirical leap from high intensity training to improved health outcomes, right? So, but there are other outcomes that we look for in patients with cardiovascular disease, particularly in managing other comorbidities, that lend itself to exercise training programs and activity programs that result in a higher net caloric volume through the week, right? So, but anyway, back to this Journal of Clin Med article that was back in 2019, March 2019. Pretty terrible month, actually. Started out well for me, and then suddenly it was just like you. We weren't doing anything for another year. But this was a program where they enrolled heart failure patients in a multidisciplinary disease management program, 36 sessions, 2 or 3 sessions a week. And this is important because if you look at the protocol, the HIIT protocol is performed as 5 3-minute intervals at 80% VO2 peak. And admittedly, that's higher than, that's at the upper limit of continuous training. And then each interval was separated by 3-minute exercise at 40%. So this is sort of and I like this approach because it sort of cuts through the middle of the HIIT protocol continuum, if you will, that we just talked about. Because you've got these you've got 3-minute intervals, 80% VO2, so it does push the ventilatory threshold. It tests that. It tests skeletal muscle, and so long as the patient can tolerate it and is asymptomatic, it doesn't have any other clinical signs or symptoms that would suggest they can't tolerate it, back them off to about 40%, bring them back to 80%. And what they discovered, or some of the findings in this, was that the VO2 peak increase was about between 14 and 20% after exercise training. And importantly, they followed these patients for upwards of 5 years, and they noted that each ml per kilogram per minute increase in VO2 was conferred a 58% improvement in 5-year mortality, which is really pretty impressive, right? When we see that relationship, John Myers and others have shown that very nicely over the years, that for every MET increase, there was a decrease in 5-year mortality rates, and the 8-month survival rate here was also statistically significant. So there's a lot of different ways. There are several different ways to prescribe exercise training for patients with chronic heart failure that get us to the same point in terms of reduction in mortality, improvement in quality of life, and reduction in reduced morbidity, right? And at the same time, hopefully, moderating comorbidities that complicate their outcomes. So I know it's, let me check my watch here. It's 12 minutes to 1, but I wanted to spend just a couple minutes on VADS, because we're seeing more VADS, and I have a long history with VADS, so I'll be pretty quick about this, but I do think that it's useful to for a moment, turn our attention from patients with chronic heart failure to those who have chronic heart failure that now have a ventricular assist device. As many of you know, that has become an alternative to transplantation, and the devices themselves have changed quite a bit. When we first started looking at this in the early 90s, we had these pneumatic VADs, and you can see here a VAD is simply cannulating the left ventricle, and where blood flows into the VAD itself, which is implanted in the peritoneal cavity. It's attached to a drive line. There's a drive line that then would, as soon as that chamber filled, about 85 mLs of blood, it would be driven back through a line that when it was sutured into the ascending aorta. And for those of you who've worked with VAD patients, it's really, especially from the time of perhaps they were waiting for a heart to the time they got a VAD, it's really quite extraordinary. It's like the movie Awakenings. These are patients with 8 to 10% ejection fractions who now actually have a reasonable cardiac output. But what was interesting in the early days was the VADs were connected to these pneumatic devices, and this actually is a pretty small one. When I first started working with patients with VADs, they actually were like shopping carts. I mean, you couldn't leave the unit because it was a bridge to transplant anyway. But there was a drive line that went in that came from this large pneumatic cart, so it was air compressor driven actually. But the ability of patients to exercise bedside. This is a young individual who developed a cardiomyopathy while hunting, actually, and then was on. I think this particular patient, as I recall, was actually on a VAD for over a year, and waiting for a heart. So, but what we discovered early on was that we didn't know much about the exercise physiology of VADs and their blood pressure responses. The pump rate of the VAD was different than the native heart rate. It was very difficult to palpate a heart rate, frankly, because it was so weak and thready. Point being that even in the early days, we treated patients with VADs symptomatically, and so that if they became lightheaded during exercise, we actually could turn up the cardiac output from the unit. But anyway, to make a short story long, as I like to say, here we go. I'm going to find my advancing slide here. In 2004, the VADs were approved as destination therapy. You can see now this patient actually has a battery pack, which eventually went into sort of like a handbag. And now the VADs have moved to the point where they are this mag leave and what are now continuous flow. So we went from, in a relatively short period of time, for patients with chronic heart failure who were continuing to fail and were either awaiting transplantation or their medicines were not able to maintain cardiac output. VADs became that bridge to transplant. And then eventually, due to the technology and the safety and efficacy of VADs, became destination therapy and became a replacement for, has become a replacement for cardiac transplantation. So now, yeah, you might be at Costco or Walmart or somewhere and be standing next to a patient with a VAD and have no idea that in fact they have a VAD, which is real. And what's more macabre about this is that they actually don't have much of a pulse. They don't really have much of a pulse either, because while the native heart continues to beat, the blood flow is effectively continuous. So as venous return increases during exercise, cardiac output increases via the VAD. So it's an intact system. And so certainly for patients with VADs, that's where perception of exertion becomes like really important, right? Because heart rate is no longer a way to drive intensity. So RPE becomes really, really important here. These are some general guidelines that have been published, and these are probably the most recent ones. That special population staff should wait about 3 months after device implant and then introducing a light resistance training program. Patients can be walking, of course, before then. And then there's just some common sense things to do, avoiding exercise that dramatically increases intra-abdominal pressure, physical trauma, because while this is intact, it still can still be damaging to VADs. But VADs have been an extraordinary advancement in the treatment of patients with chronic heart failure, and they will benefit from exercise training, of course, to the same level as their colleagues. Their cardiac output has just been moderated, if you will, by the device itself. So and I don't know how many of you are encountering patients with VADs. We don't have a lot of places, in the region that where VADs are part of the protocol. But coming to a theater near you soon, I'm sure. I think that might take me to the thank you slide, and with a few minutes to go. So I think I can probably, let me stop my screen sharing and see if there's anybody awake out there. This is so odd. As we all know, an odd way to do lectures. But last year, my one anecdote was that we did all remote graduations. And so I got to do like 6 different graduations. And but what was so weird about it was I felt like I was just talking to a Word document. And there were like hundreds of people on the other side of the screen. So I'll stop.
All right, Reed. There's a few questions here in the Q&A area. The first one, so would you say looking at left LVEF, so the ejection fraction itself, is that not the best way of deciding how you should evaluate a heart failure patient entering a program?
Yeah, it's not actually, and thanks for that. Thanks for that question. The even you go, I guess I'm just really old now, but even Nanette Wenger, like one of the elder statespeople of cardiac rehabilitation, even before we were admitting patients with chronic heart failure, made the observation that it's far less about ejection fraction than it is actual volume that's actually leaving the left ventricle, right? So so ejection fraction informs one about about the relative risk of a patient. We know that's true, but it's really the volume that's ejected by the heart, and it's not, for me, it's never been the principal driver. I remember, of course, when I started my career, it was like, oh my gosh, like low ejection fraction equals, patient at high risk, and they are high risk, of course, below 30%. But because they have such significant differences in overall VO2, VO2 to me, their fitness rather, and their functional status, if you will, because you could have a low EF and have pretty good functional status, became really the principal variable for me. It's less than ejection fraction. I hope that answered your question.
That sounds good to me. That's kind of what I've always been taught to and always learned is you can't really hang your hat on that EF too much. You still got to evaluate the patient for where they are. So another question on there is, what about heart failure patients that you're not seeing the best blood pressure response with activity? Would you recommend smaller multiple sets of activity versus long steady state of activity? Or what would you recommend with poor blood pressure responses in heart failure patients?
Well, I'm going to presume by the question that we're talking about a hypotensive response or just a modest response in blood pressure. But again, I still would treat it symptomatically if because some patients will have a relative, what would appear to be a relatively hypotensive response or low response to exercise, but but blood pressure, like heart rate, is really a physiological response more than anything, right? If it doesn't result in signs and symptoms of cardiorespiratory or cardiac distress, I don't pay much attention to it. I think then it really, I still think that I would, I guess what it would suggest is that the volume of exercise or going to repetitive bouts is a negotiation between the clinician and the patient. But I think there is some logic to thinking about short duration, like a lower intent, a short duration, like short bouts of exercise with rest. But I would really let the symptoms drive that. Because blood pressure response, the longer you practice, the more you realize, man, blood pressure responses are can be all over the map, and I don't want that to really dictate how I'm driving therapy. So if they stay within the limits, that are established by a facility or guidelines you follow, but they're asymptomatic, I think it's then you just try to arrive at the best available exercise training regimen that they'll stick with. I think that's really important. I always say that. When I taught exercise phys, I used to say that, because we always have individuals say, well, I'm only in zone 2 of my heart rate during exercise, and I should be in zone 3 or I should be in zone 4. And my response always was, the most important thing about heart rate is to have it. Beyond that, it's simply a physiological response to the challenge that you're inducing for to improve cardiorespiratory fitness. So I hope that's helpful as a response. Casey?
Yeah, I think that sounds good. I guess my own question that I just formulated out of that for you, not necessarily with just heart failure patients, but in cardiac patients in general, where do you sit on the idea of continuously checking exercising blood pressures their entire time in a cardiac rehab setting? Where are you at on that?
I think that less is better. If there's no evidence coming into the cardiac rehabilitation program that the patient has unusual or abnormal blood pressure responses, I treat them symptomatically. I really wrestled with this for a long time because I was on the front end, if you will, just because I'm old again. I was on the front end of ECG monitoring during exercise, and I came out of like a university program where we didn't monitor ECG. And then it was like, oh, well, now we're going to monitor everybody for in phase 2 rehabilitation programs, and it's helpful, but there's always a balance, right, between creating a patient creating a dependency on like, oh, I can't exercise unless somebody's looking at my ECG, right? But I think once individuals are screened, feel safe, our job is to make them feel comfortable and discharge them as soon as possible so they can self-manage. So unless there's a really compelling reason to measure blood pressure, I would do it less, particularly if the patient began to think that that was like a critical variable that they couldn't, they can't have. I was just say can't live without, but of course that's probably the wrong vernacular. But I think less is better. Moving patients to home exercise programs is really important.
Great. Sounds good. Yeah. That kind of covered the questions there. And I think we're at the time. So, Reed, I can't thank you enough for being able to do this for us. It was wonderful presentation. I know me as a clinical exercise physiologist ate that up pretty good. So, thank you again for your time and presenting for us.
Casey, my pleasure, Mike, and those who are able to be on the call. I really enjoyed the opportunity to step out of my current role to do this, and likewise, and people know how to find me. I'm easily found on the internet, and if you have a question, a follow up, or anything, please send me an email, and I'll be happy to get back to you. So, with that, I'll say goodbye because I think I got like a 1 o'clock Zoom meeting.
Sounds good, Reed. Thank you again.
You bet. My pleasure. Take care, everybody. Godspeed. Get your vaccinations. See you now.